We'll be heading off to California in a few months to a continuous fellowship training. So we welcome him today, and he's going to be talking about aortic valve calcification and AI. So welcome.
Thank you very much. So it's a pleasure to be presenting today. Thank you for having me, of course. Here are my disclosures. So it won't come as a surprise to you that aortic stenosis has increased in prevalence with the aging of the population, and that really the main pathophysiological process that leads to aortic stenosis is aortic valve calcification. So that'll be the topic of today's presentation. So we'll talk about pathophysiology of aortic valve calcification, imaging modalities that are used in this context. We'll talk about clinical implications in aortic stenosis, as well as with procedural implications. And then we'll talk about some of the work that we've been involved in at the Heart Institute with the automated quantification using AI methods. So let's start with that pathophysiology. So the normal aortic valve is composed of three leaflets, as we know, and these are normally thin and pliable, and they're attached along a crown-like line at the level of the aortic root. At the base of those three attachment line lies the aortic valve annulus, or the virtual ring, and the root in the aortic aspect that is bounded by the sinusotubular junction. So we're quite familiar with that structure, of course. Now, from a histological perspective, there's two types of cells that are mainly involved in at the level of the valve. So we have endothelial cells that cover the surface of the valve, and then you have valve interstitial cells. And those are arranged in three layers. So starting at the aortic side, you have the fibrosa that is composed mostly of collagen in addition to those cells. You have the spongiosa, which has glycosaminoglycans, as well as those interstitial cells, and the ventricularis on the ventricular side with mostly elastin. So in the aortic stenosis, there's multiple, risk factors that will predispose a patient to aortic stenosis and aortic valve calcification. So metabolic syndrome, obesity, hypertension, smoking, renal failure, dyslipidemia, male gender, oxidative stress, and age have all been implicated in this process. And as we know, once patients develop symptoms, the mortality is over 90% within a few years. So that brings us to the current model for the pathophysiology of aortic valve calcification and aortic stenosis. So there's really two phases: an initiation phase and a propagation phase. And the initiation phase is actually quite interesting because it's very similar to atherosclerosis. So it starts with an endothelial injury at the level of the valve that is followed by lipid deposition and inflammation. So that is the initiation phase. And once the process is initiated, what will happen is those valve interstitial cells within the valve will then become differentiated into osteoblasts. And osteoblasts will lay down collagen that will eventually become calcified, initially with microcalcification and then macrocalcification. And what then happens is you get areas of compliance mismatch. So areas of the valve that's diseased, area that's not diseased, and really at the interface between those regions, there's mechanical stress, and that actually triggers further osteoblast differentiation. So that is the process that we think is self-propagating, really, and not driven really by inflammation and lipid deposition as much. Interestingly. So let's talk about imaging and how the imaging of the valve actually helped us to develop this model of pathophysiology in the aortic valve calcification. So three modalities to discuss. So echocardiography, PET imaging, and then we'll talk about CT. So echocardiography, of course, has a major role in aortic stenosis. So plays a crucial role for diagnosis, evaluation of patients, of course. And back in 2000, there's a paper that was published in the New England Journal of Medicine that described the kind of a visual scale for calcification of the aortic valve, from a 4-point scale, and they they demonstrated that there was a prognostic value to that 4-point scale. Interestingly, that's what Dr. Masika noted. You can't really have severe aortic stenosis if you don't have calcification of the valve. So, of course, if you have patients with no calcification, those patients will do better. So that kind of makes it more understandable why there is that severity or prognostic value that was developed. Really, the issue with this is that, as anybody who's read echoes before, there is some inter-observer reproducibility issues with the aortic valve calcification on echo, and there is some variability between different readers. So another modality that's been studied in AS is positron emission tomography, or PET. So two tracers have mainly been used in this context. So FDG, and as we know, FDG is taken up by metabolically active cells, and it accumulates intracellularly. And then, especially on the vasculature, we think that this is mostly macrophages that will accumulate this tracer and lead to higher uptake. And it's a useful tool for vascular inflammation in this context. Now, another tracer that's been available for many years is sodium fluoride. Essentially, that tracer actually detects areas of novel calcification. So regions where calcium is either being remodeled or deposited. It's useful clinically for osteoblastic tumors and bone metastases, but it's also been studied for aortic valve calcification. So here's some of the images in patients with kind of increasing severity of calcification, both with sodium fluoride and FDG. And what we see is that the correlation between severity on echo and the tissue to background ratio on PET is really much more correlated for the sodium fluoride than for FDG. There is still an increase in FDG, but not quite as dramatic. And then actually on histopathology, the increased FDG activity on histopathology did not correlate with increased macrophage activity. So they used CD68 markers and did not see that. So it's actually thought to be a marker of osteoblastic activity in the valve and less inflammation at that level. For sodium fluoride, that has a much stronger signal on the valve, and it has a clear correlation with disease severity. And that really supports this hypothesis that calcium begets calcium, really that propagation phase of the pathophysiology. So as more calcium gets deposited, it accelerates the deposition of calcium, and there's much more activity on the valve. It has been demonstrated that there is some predictive value to sodium fluoride tracer for the aortic valve, and it is a predictor of future AVR in the patient, aortic valve replacement, or of cardiovascular mortality. And those really are similar to really the baseline calcification severity. So it's not a predictor much above that. And it's really used as a research tool, as we'll see in some of the trials we'll discuss today. Now, CT, of course, has been used for many years, and CT calcium scoring in particular has been studied extensively for coronary artery calcification by Agatston and all, starting in the 90s. The same method has been applied for aortic valve calcium scoring. So you really need, in this case, a CT scan that's ECG gated, non-contrast, usually acquired in diastole. And then the score itself accounts for two aspects: the volume of calcium and also the density of calcium. So there's a well-described method that allows us to calculate the Agatston score, and it's the exact same as with coronary arteries. Dr. Masika has done some pioneering work on this starting in 2004 with a publication that showed that the CT-AVC score correlates with the mass of calcium from explanted valves. So there's a clear correlation with that. So that is kind of the prerequisite for this to be used as an imaging modality for quantification. And it also correlates, interestingly, with the AVA and the peak pressure. So that was some of the early data that we had that correlated CT-AVC with hemodynamic severity. It was then used extensively in the diagnosis and studied extensively in the diagnosis of aortic stenosis. And there's been multiple studies on this topic. Each study that somewhat different threshold until 2013, when Clavel and al. Had the largest study published to date, and they really looked at the predictive value of aortic valve calcification to detect a valve area, an index valve area of 0.6 in particular, or a mean gradient over 40. And they established these thresholds that really offered the most optimal diagnostic performance. Another metric that was also used in that study is the AVC density. So in this case, it's quite simple. You get the aortic valve calcium score and you divide it by the aortic valve annulus area. So that's another metric that's been studied in the literature, and what we'll come back to in a few slides. Another interesting aspect is really the sex difference. So why do we have a different threshold for women and men? Why not just use an indexed value for body size? Well, interestingly, in this specific study, we found that women incurred a similar aortic valve severity from a hemodynamic standpoint, but for lower aortic valve calcium threshold. So that really led the field to consider sex as being having a really a determinate process in the development of aortic stenosis. And that's why really two thresholds are being used today. Now, the aortic valve calcium score has also been used to predict clinical outcomes in aortic stenosis. And we come back to our two metrics, AVC and the AVC density. And really, both of those were found to be predictor, and they're an independent predictor of poor survival in medically managed patients. So patients who are not intervened upon with surgery, they do worse with increasing level of aortic valve calcification, with severe level in particular, based on the threshold from the early study. So quite interesting, and there's slightly better predictive value with the density metric, which is quite interesting. Now, in terms of progression, so really the only well-established, validated marker of progression in aortic stenosis is the baseline severity. So if you have severe AS at baseline, that patient will progress faster. And that's true in the context of aortic valve calcification, so anatomical severity, as well as hemodynamic severity. And Nadav Wilmer, who's a fellow here a few years ago, published this paper when he was here and really did a meta-analysis of study and really further strengthened this concept. Recently, in the last year, lipoprotein has also been studied in terms of its impact on progression and whether it would have a predictive value for progression. It was found that it is not associated with progression of aortic valve calcification, but it is a predictor of onset of aortic valve calcification, and that's further data towards our model of the pathophysiology with the initiation phase. So LP(a), lipoprotein A, would be playing a role really in the initiation phase, not in the propagation phase of the disease. And they also provided further data that supports this concept of self-propagation, with the baseline aortic valve calcium score being the main determinant of progression. Now, guidelines now recommend CT aortic valve calcium scoring in patients with suspected low flow, low gradient aortic stenosis and patients with discrepant hemodynamic data. And that's both in the American guidelines and European guidelines. The thresholds are suggested. The American guidelines is 1,300 in women and 2,000 in men. I think we're quite familiar with those if you're caring for patients with aortic stenosis. So let's talk a bit about therapy for aortic stenosis. So there's been multiple medical therapies that have been studied for calcific aortic stenosis, and we'll talk about those briefly. So statins were the initial agents that were studied in large, well-designed RCTs, but really failed to show an impact on hemodynamic severity as well as clinical outcomes. So really negative trials in patients with mild to moderate valve obstruction. And again, that is supportive of our model of the pathophysiology. Those agents may be playing more of a role in the initiation phase rather than in the progression. So once patients have mild to moderate valve obstruction, they likely play a much lesser role. Bisphosphonates have also been used, and bisphosphonates really will decrease bone reabsorption in the bone level, which will decrease the available calcium and phosphate to be impacting the valve potentially. So this was studied. Another agent, so denosumab, that we know well for treating patients with osteoporosis, for example. So denosumab will bind the rank ligand. So it's a monoclonal antibody that binds rank ligand, and that will play a role in the differentiation of osteoclast in the bone level, and also potentially at the valve level for valve interstitial cells into osteoblasts. So that was a thought in terms of the pathophysiology of how those agents would work. Unfortunately, there was a study published very recently in 2021 that showed no impact on progression of aortic stenosis. And that's in terms of the aortic valve calcium score, in terms of sodium fluoride, PET, and in terms of echo parameters. So really no significant impact with denosumab or alendronate in this case. Vitamin D and calcium, also quite interesting. So this is a study from Cleveland where they looked at their echo database, and they found patients who had been receiving vitamin D supplementation and calcium supplementation. And they found a signal for all-cause mortality in patients with moderate aortic stenosis, mild to moderate aortic stenosis. So potentially calcium and vitamin D may be associated with more rapid progression and outcomes potentially in aortic stenosis. Another agent, another vitamin K, has been studied and associated with as a potential reduction agent in measures of cardiovascular morbidity and mortality. And the main thing that it does is vitamin K basically decreases calcification of the vasculature. So it's a potent inhibitor of calcification. So it was thought that it may have an impact on AS, and this was studied in the multi-center RCT that was well powered, and they gave vitamin K and vitamin D in complement for 24 months, and unfortunately really no impact on AVC progression. So same amount of calcium increase between the intervention and placebo group. So unfortunately no impact. Now we talk about vitamin K, but what about vitamin K antagonists, so warfarin? So interestingly, warfarin was studied again in the same cohort from the Cleveland Clinic. They looked at patients with mild to moderate AS, and they found that warfarin, either compared to no oral anticoagulation or compared to a DOAC, actually was also associated with all-cause mortality, even with an adjusted analysis. It also led to faster progression in terms of severity of aortic stenosis, hemodynamic aortic stenosis. So quite interesting data that just was published last year. Again, it's an association rather than a causation, because this is not a randomized study. So to summarize, medical therapy for calcific AS, really no RCT has demonstrated an impact for AS on clinical outcomes. Vitamin D, calcium, and vitamin K antagonists really are associated with worse prognostic outcomes. Now, in terms of aortic valve replacement, so switching gears, we've really seen over the last 10 years a very significant increase in the number of transcatheter aortic valve implantation that's been performed. This is data from the US, but we see that starting in 2017, it's overtaken surgical aortic valve implantation. And we see that probably patients with less morbidity are now treated with, and less comorbid patients are treated with TAVI now that the most recent clinical trials have been published. So the mortality in hospital has been decreasing throughout that decade. So there's a few implications for aortic valve calcification in TAVI in particular, and we always think of the possible complications of TAVI, and we'll briefly discuss how those are impacted by aortic valve calcification. So early on in the history of TAVI, paravalvular leakage was a big issue, a major issue, and you may remember Philippe Généreux had published this article that linked the severity of post procedural paravalvular leak to mortality in patients with undergone TAVI. So definitely this was a major issue, and it's early on in the history of TAVI, this was studied in terms of the impact of calcification on paravalvular leak. And we in this study, they found that if there was calcification in the LVOT in particular, or a very severe calcification at the leaflet level, this was linked to increased risk of paravalvular leak. With the development of second generation devices, those have now a skirt, a sealing skirt on the ventricular aspect of the device. Really, the incidence of severe or more than mild paravalvular regurgitation post-TAVI has drastically decreased since then. And really, the aortic valve calcium score now is not a predictor of major regurgitation post-TAVI. And that was demonstrated in a recent study. Now, conduction abnormalities. As we know, about 5 to 15% of patients who undergo TAVI will then have a conduction abnormality that will develop and may require to have a pacemaker implanted. So the association between the aortic valve calcification and pacemaker implantation is somewhat controversial. So some studies that showed really no association between the AVC score and needing to have a new pacemaker. And some study in self-expanding valves in particular showed a very weak correlation in this case. However, the association that was more significant was really asymmetric calcific burden. And the studies have really looked at calcification and found a link with calcification of the left coronary cusp. So that's quite interesting because the left coronary cusp is opposite to where the conduction system is located within the ventricle. So it's thought that the calcification on the contralateral side will apply more force on the non-coronary cusp and the right coronary cusp, and that is the location really what the left bundle is traversing on the surface of the membranous septum, just on the ventricular aspect of the membranous septum. So that has been linked there. So there is some data for asymmetric burden. Now, root rupture is also a devastating complication of TAVI, and really the main features that have been well established, moderate to severe LVOT calcification, that is one of the main feature, and device oversizing over 20%. In the early data, in this study, they had looked at about 30 patients who had root rupture, and they had matched them with patients who had not had a root rupture. They found that if there was calcification of the right coronary cusp, in this case, patients would have an increased risk of root rupture, and those were more represented in their rupture cohort than in the non-rupture cohort, interestingly. More recently, in 2020, these authors really defined severe LVOT calcification based on the appearance of the calcium. So they look if there's more than 5 millimeters in any direction or more than 10% of the perimeter of the LVOT is affected. They define this as severe calcification. And then they looked at basically the rate of root rupture, and they found a significantly higher rate when there's severe calcification based on that definition. They also found that balloon expandable valves were more subject to root rupture than self-expanding valve in severe LVOT calcification. So that may provide some data to use a self-expanding device when LVOT calcium is present. In terms of coronary ostia occlusion, another complication, the main really features that are associated with that, the height of the coronaries and the size of the sinuses of Valsalva. So less than 10 for the distance to coronary vessels from the aortic valve annulus, and sinuses less than 28 millimeters. There's no association that's been demonstrated with calcification in that case, interestingly. As stroke, as well in the early studies was a big talking point because there was a signal for increased stroke with TAVI compared to surgery. However, in the later trials, this was not demonstrated, and there really was no significant difference in this case. But there was a lot of research that was then devoted to stroke in post-TAVI patients. And in this cohort, they looked at subclinical stroke, so small lesions on MRI, and they correlated it with the calcification score of the patient. So patients who have more calcification will get more of those lesions. So higher risk of periprocedural cerebrovascular event. This led to the study of cerebral embolic protection devices, and this is a study that was published very recently, looking at the impact of those protection devices during TAVI, and really did not have significant impact on the incidence of pre-procedural stroke. So interesting data about this, but really no impact. So now I'd like to switch gears and talk a bit about the work that we've been involved in at the Heart Institute. So we know that aortic valve calcium scoring using CT can be time consuming, despite it being now recommended by guidelines, and can be prone to errors in centers that are not as used to doing this and as experienced in doing this type of measurement. Recently, convolutional neural networks have been developed and are now heavily used in cardiac imaging, with many publications every year, now well over 1,000 a year on the topic. So definitely a massive impact. And we've had the privilege to be involved in some research on this. Whenever we talk about research on AI in particular, we really need to have massive amount of annotated data in order to train the algorithms. And some of the ways that we're able to annotate the data is using very well-tailored software to do that. And we've been involved in the development of some of the software aspects of this. So as we know, when we acquire a CT scan, images are stored in DICOM format and then need to be imported in order to be annotated and analyzed into a workstation. And those workstations, there's several of them that are clinically available. They're really quite user-friendly, but they're all proprietary. And in terms of the format that they save data into is really hard to use by researchers. So they're not well suited to really research in AI, unfortunately. There are some research software that have been proposed, but those are somewhat difficult to use by clinicians. They're really much more research tools, and some of them, like the Autoplaque from Cedars-Sinai, is not really available for other centers to use. So this led us to develop our own software, and we really wanted to bridge two aspects with this software. We wanted to provide an easy-to-use software for interventional cardiologists planning structural intervention, but we also wanted to use the platform to power AI research. So that was the vision we had for the system. And just very briefly, the software itself has 4D visualization for CT scans. It has volume rendering with a few different modes, such as an endovascular mode, fluoroscopic mode, or an X-ray mode. We also have, vascular access evaluation that's been developed, and some 3D measurements. And because we've used a kind of modern software architecture for the development, it's actually a fully multi-platform software, so we can actually use it on a cell phone. And now cell phones have become quite powerful, so you can actually analyze the CT scan, look at the size of your aortic valve annulus on your cell phone if you need it. It's a kind of a side effect of using a nice modern platform for the development of that. So we've used this initially for aortic valve annulus planimetry. So that was the first project that we developed. So as we know, for sizing TAVI in particular, we use the aortic valve annulus size, which is at the base of the three leaflet attachment lines, as we know. And there's really guideline recommended methodologies to do this and obtain this plane within the CT scan. And it's not the thing about the aortic valve annulus is it lies oblique, so you can't obtain it well in an axial slice of the CT scan or coronal or sagittal. So there's really an oblique structure. So you need this kind of a methodology to find the valve annulus. So what we developed is an algorithm to automatically locate the valve and then find the orientation of the valve automatically within the CT scan. So the method that we used for this is a multi-scale algorithm. So you can imagine we start with a very coarse CT scan. So we make it only a 64 by 64 by 64 matrix, and we take a guess, like we have the algorithm take a guess as to the location of the valve within at that level of detail, and then we zoom in onto that region of the valve. We take a second guess now with a finer scale around the valve, and then we then complete this once we get to close to the native resolution of the CT scan. And at the last step of the algorithm, we then get both the location and the orientation of the scan of the aortic valve annulus. So we've trained this in 94 patients, and we use phase CT scan. So we really had over 1,000 annotated CT volumes that we used in this project. And what we found is that as the algorithm progresses and as it owns in onto the aortic valve, the error in terms of the localization of the valve center gets smaller and smaller. And then the last step, we're able to get it within about 1.4 millimeter, which is the size of about 2 or 3 pixels in the image. So it's really quite accurate. In terms of the error, in terms of the angle of the valve, so the plane of the valve itself, we were able to estimate the angular orientation of the valve within about 6 degrees, roughly. And the error is within 10 degrees in close to 85% of patients. So that's close to what expert level accuracy using that guideline suggested method from previously. And then we used kind of this orientation and the plane that it provided us to measure the aortic valve annulus in that view, and then we were able to find that we had about 5% error for the aortic valve area and about 2.5% error for the perimeter. So quite accurate measurements that are really close to human level reproducibility. We then shifted our interest to aortic valve calcification using AI, and we developed, using the software, tools to annotate the images, and then we had a number of collaborators annotate CT scans using the software, and that really gave us the freedom to have, to control the format of the data and have those really easily accessible and easily imported into machine learning frameworks. We collaborated at the Heart Institute with MITRE, which is a nonprofit U.S. research organization. They're quite large with more than 8,000 employees. They do a lot of work in aviation, defense, healthcare, cybersecurity in the U.S. in particular. And we've had the privilege to work with them on several AI projects and data science projects at the Heart Institute. So the algorithm we designed in collaboration with MITRE is really in two phases. And you'll recognize the initial phase because it's very similar to what we talked about for our planimetry project. So that in that phase of the algorithm, we really try to own in onto the location of the valve and find its orientation. However, in this case, the CT scans were not contrast enhanced. So that's the big difference with our previous work. So really, we find the valve location really on within the non-contrast enhanced CT scan, very similar in a very similar way than we had done in the previous project. And then we use this data in the second stage of the algorithm. And the second stage is a segmentation stage. So the idea of segmentation is to really determine if a pixel is calcium and if it's part of the aortic valve in particular. So that's the idea of what segmentation is. There's multiple algorithms that have been proposed to do segmentation of images. It's a very classic problem in medical imaging in particular. And in computational imaging more generally. So there's this architecture called a UNet that's been developed where the image is taken in on the left side of the neural network. You have an encoder phase of the neural network followed by a decoder phase. And then what you output at the end of the neural network is really a mask of the calcification. So basically an image where 0 means the pixel is not part of the valve calcium, or 1 if it is part of the aortic valve calcium. Now, the innovation that we brought to this is we wanted to integrate the information from the first stage of the algorithm into this second stage of the algorithm. And the way we did this was with a multi-channel approach. So you can think of channels as colors, basically, in the image. So what we provide here is every pixel in the image has several data points. So we have a channel. Basically, if you could think of this as the color red, that's just the CT scan, the raw CT scan. Then we have the second channel, which is the total calcium mask. So that will be calcium that is part of the valve or not part of the aortic valve. So it could be part of the coronaries or the mitral annular complex, for example. And then we also wanted to integrate the orientation of the valve and the position of the valve into the algorithm. So that we provided with basically a map of the radial distance. You can think of a kind of a hockey puck being aligned with the aortic valve, and you can think of the radial distance as kind of the distance from the center of that hockey puck, and the axial distance, the distance up and down along the hockey puck. So that's what we basically used and provided that to the algorithm. We used, TensorFlow, which is a standard library for machine learning. We use patients' scans from the Heart Institute. So we had 726 CT scans in patients with aortic stenosis. The mean age of those patients was 82 years old. 44% were women. And, in terms of hemodynamic severity, so the mean pressure gradient in those patients was 44. So definitely in the severe range. The mean aortic valve calcium score in that cohort was close to 3,300. So quite heavily calcified valves. In terms of pressure gradient, 60% of those patients had met criteria for severe AS in terms of pressure gradient. In order to have a group of patients without calcification, we also added a control cohort of 119 CT scans, essentially patients who had consecutive, calcium scoring for another indication. And we found that in those patients, the AVC score was less than 195% of cases. So we use both of these cohorts to train the algorithm. In order to train the algorithm, we had to annotate the images, and we had 4 physicians who used our software to do that. And the task was twofold. So first, a landmarking. So they placed position markers on within the valve on the commissures, as well as the center of the valve and the coronary vessels. And really, the reason we wanted to have this data annotated is because the the distribution of calcium has been linked to outcomes, especially in TAVI, as we saw earlier on. So we wanted to have that data available, during our analysis. And then in terms of segmentation, really, we did this using the tool that I demonstrated earlier. So in terms of our results, so these are images, sample images at 3 different levels of accuracy. So accuracy in the 5th percentile, 50th percentile, 95th percentile in terms of position for the first 2 columns, and in terms of orientation in the last 2 columns. And we found that the algorithm performed quite well. So for a 3D position, we found an accuracy of 2.7 millimeter error. So that quite accurate, not quite as accurate as with the contrast enhanced scan, but you can imagine there's no contrast in these images. So the soft tissue structures are much less well defined. So you can imagine that the algorithm would have slightly more difficulty. However, this was, quite an accurate, approximation of the valve position that could be used in the algorithm as a first stage. In terms of angular error, we reach about 10%. Angular error in this case. Again, slightly worse than with a contrast enhanced scan, but still appropriate for our purpose. I think it's, the presentation is frozen, unfortunately. Oh, there we go. We also then looked at segmentation and how accurate we were at segmenting the aortic valve calcium. So using the algorithm, we got an absolute average error of 164 units in terms of calcium score. And we also evaluated inter-observer accuracy, and we found that there is humans slightly outperformed the machine still at that level. So slightly better performance with the inter-observer reliability, and that's only in the absolute sense. Once you get to relative amount of calcium and relative error, there is no difference that we could find between the machine and the human. These are some of the Valent-Hellman plots that we produced for this. So this was the algorithm within versus a human, and we can see that there's no systematic over or underestimation of the calcium score, and this was the inter-observer difference. So we also evaluated correlation and found strong correlation between the reader aortic valve calcium score and the model predicted score. And then we divided the accuracy by segments of the aortic valve to see if there was any effect that we could elucidate from that. And we found that the algorithm performed slightly worse at the level of the valve than at the inter-observer reliability, but in the LVOT slightly outperformed the human reader. So slightly better within the LVOT level, and that's an important level for quantification in patients with who may undergo TAVI, for example. And then we evaluated classification of patients into severe and non-severe aortic valve calcification and found a high accuracy of 96%. And it was similarly highly performant both for men and women in our study. And we compared for this task our algorithm with other more out-of-the-box algorithms that have been used for segmentation. And we found that our multi-channel approach did provide some benefit, even if with an out-of-the-box kind of neural network that was used. So we definitely improve the diagnostic accuracy in that case. And our final model used a more advanced architecture for the actual unit that we used, and really that really outperformed the other approaches. So to summarize the research that we've done, so we proposed the landmarking algorithms that accurately localize the aortic valve, and that was served as the input to the second stage of the algorithm. And for the segmentation stage of the algorithm, we achieved an absolute and relative error that approached human level accuracy in this case. And it was most accurate at the level of the leaflets, and least accurate in the LVOT calcium, interestingly. In terms of the combine algorithm, it really performed very well to differentiate patients in terms of severe AS severity. So we're very grateful for the funding and support from the Heart Institute and the support for intellectual property protection that we received from the Heart Institute for patent protection. So we're very, very thankful for this. In terms of future direction for this project, we're embarking on a clinical evaluation of the algorithms. And what we want to see is whether it provides a benefit in terms of accuracy, reproducibility, and analysis time compared to humans, basically. So that's the, the first stage of our future directions. We also would like to evaluate outcome predictions with this. So we're gathering a cohort of patients that have those outcomes well delineated. And one aspect of the project is we can actually automate now the CT analysis potentially for TAVI planning as well. So that's a type of CT scan with contrast, and we hope that we may automate prosthesis sizing and as well as vascular access evaluation and the root evaluation. So to summarize our presentation today, we discussed the pathophysiology of aortic stenosis with the two phases of the pathophysiology. We talked about different imaging modalities that are used in the aortic valve calcium evaluation, and we talked about clinical impact implications in patients with AS as well as patients undergoing TAVI, and we talked about our project at the Heart Institute. So I'm very thankful to my collaborators. Dr. David Mesika has been a fantastic collaborator on this and mentor. So huge thanks to him, as well as Dr. Piazza for his guidance at McGill and the work that we've been doing together on our software, as well as Dr. Chow at the Heart Institute. And we're extremely thankful for our collaborators at MITRE, Andy, Jocelyn, and David Slater have been amazing collaborators. So really a pleasure. And of course, the leadership of the Heart Institute's been extremely supportive. So I leave you with it seems to be these days that any AI talk cannot be complete without the ChatGPT, reference. So I asked ChatGPT to write me a poem about aortic valve calcium scoring. So I'll it's quite an impressive little poem. So I'll let you read it at your own leisure. So thank you very much.
Thank you, Pascal. That was outstanding. Congratulations on that body of work.
Thank you.
We'll wait for people to add any questions into the chat. If you do, we'll address them. I'll start with the questions, and probably a naive question from an AI perspective, so you can talk me through it. But if you build your software or you build your program with humans as your gold standard, what if we're wrong? So how do you, and my understanding of AI, and this may be a very simplistic view, is that the AI should learn over time and get better. So at what point, is the machine actually correct and we're not?
Yeah, it's an excellent question. I think the strength of a lot of the recent AI revolution has been exactly this point: robustness with very noisy data. So data that is not necessarily perfect can still be used to train algorithms. So ideally, you'd want perfect data, of course, and you don't want data that's systematically incorrect, of course, because anything that has bias, if you introduce bias in your data, you will get a biased answer out. So that definitely is a big issue in the development of AI. But once you can tolerate some incorrect data, and that will have a small impact in the algorithm, but it is actually quite robust in the training process and can account for this. But of course, you don't want systematically biased data, and that's been shown to have major impact in the care of patients. I'd presented last year on this, but in dermatology, for example, AI algorithm trained in patients with fair skin really did not perform well at all in patients with darker tones of skins. So for detection of cancer kind of lesions, for example. So definitely you want to have an algorithm that's trained and non-biased and very well evaluated. So that absolutely is true. Yeah.
I think there's another question here in the chat from Dr. Ruel. His comment is very impressive, Pascal. Um, a great tool for the future in and many other applications. Which of those new applications do you foresee?
Yeah, it's a great it's a good question. I think medical imaging is the most obvious application because the data is the cleanest, I would say, and there's a lot of great algorithms that can handle image data. So I think that's an easy application. Now the next big field that is being investigated is large language models, and that's what ChatGPT is an example of. So really being able to synthesize information and to present it succinctly. So you could imagine in the future having clinical notes now having an initial kind of AI generated format in the future. So you could definitely see that. And if you practice clinical medicine, you know that clinical note writing is definitely a big burden on the system and on the time of clinicians. So potentially what we could achieve in the future is really taking those rote and repetitive tasks that people are performing over and over and make them much more automated and really use clinicians for what they're best at, discussing with patients, having a relationship, and summarizing and synthesizing the information and really advising patients rather than clicking on images and writing notes all day. So I think that will be likely, I hope, the main impact of AI in the future. So really, that's what I foresee.
I think you kind of answered Dr. Nair's question as well when he asked, we have to wait for AI to be self-sufficient, and do you think that's going to happen? So
Yeah.
you kind of addressed that a little bit.
Yeah, it's interesting. I mean, if you listen to podcasts on AI recently, with ChatGPT coming out, there's a lot of hype right now about the power of AI and how exponential the progression has been. And I think people now foresee a very rapid exponential kind of progression of the field. So we expect that every year there'll be major findings and the capabilities are likely to continue in this direction. Again, AI has seen many booms and busts along the years. Back in the 70s, it was first developed and it really had reached a plateau and eventually lost favor. So I hope that now with the increased power of computational power, we may reach the point where AI can have can continue to grow over many years, and that's what I foresee happening.
Dr. Kwan Chan asks, this data applies to degenerative aortic valve disease. Is there any data on bicuspid aortic valves?
Yeah, it's a good question. I mean, we know that patients with bicuspid aortic valve will develop aortic valve calcification more readily, and I think that fits within the pathophysiology as well because when you have a patient with a bicuspid valve, the stress on the valve, becomes is affected and applied in different manner than in a tricuspid morphology. And there's a thought that really only that hemodynamic component with the propagation phase of the calcification would likely have the most impact in patients with bicuspid aortic valve. And that's why they tend to develop aortic stenosis earlier than patients with a tricuspid valve. So that's my thought on that.
Pascal, fantastic. Really fantastic. Great work, great leadership in this area.
That's very good.
Thank you for all your work and congratulations on your project. And so glad to see you moving it forward to look at how we can impact analysis and potentially prognosis and so on. So I have two questions. One is you're using this and you've applied this in severe AS. To kind of basically generate the calcium score in a much easier, more efficient way. But you also showed data earlier in your talk about how milder calcification begets calcification, predicting progression. And so that population of mild was relatively small in your group. And so I guess my question is, will you be looking at that? And what are your thoughts about, milder calcification? And kind of related to that, the population that's been studied, like you pointed out in the dermatology study, is there biases in our population, but the population that you've studied that may or may not make it broadly applicable?
Yeah, that's a great point. And of course, you want to have data that's as representative of the population you're describing. And definitely our data set was more heavily kind of biased towards more severe aortic valve calcification score, but we did have a significant portion of the scan of the data set that was at the lower end of the calcium score, and we did do an analysis, and I didn't have time to present that, but we did stratify the our evaluation or quantification of the accuracy of the algorithm by calcium score. So we looked at less severe scans and patients who had more calcification and performed really quite well across the board. So it didn't seem to have a biased performance based on the amount. So luckily in our data set, this seems to be the case. Absolutely, you want to have external validation of the algorithm. So that's a key aspect, and that's exactly what we're adding right now. So what we did is extracted all the patients who had a CT aortic valve calcium score at the Heart Institute last year. 256 patients had a scan like this, and we're reapplying the algorithm. And in those patients, really the score is much more in the lower to intermediate range, because those patients are followed longitudinally, often in David's clinic. So those patients will really allow us to address that problem. So that's a great point.
One more quick clinical question from earlier in the talk. What should we be telling patients who are on calcium and vitamin D if they have mild AS or aortic sclerosis?
I think that's still an evolving field. I don't know that there's any clinical guidelines that have addressed that, and it's really an association that we've demonstrated in those studies rather than a causality. I think it would be, if the patient has a clear, strong indication to be on those medications, I think it would be probably unwise to stop it. But if they have a very weak indication, it may be considered to stop those medications. I think you have to consider the patient, of course, and the full clinical picture.
And the study were biased because they were retrospective.
Yeah, exactly. The retrospective.
The robustness of the data is quite weak. I have no question. I would like to thank you, to congratulate you. It's a great pleasure to work with you. First, you're an excellent clinician. I have the chance to work with you in clinic. You're an excellent researcher. And for those who don't know, you have a third gap, which is you have a PhD in physics. And it's amazing because you are dealing with all the technical problems and sometimes I don't understand when you talk with Miter. So again, thank you.
Well, that's very kind. I really appreciate this. It's been a pleasure working with you, David, as well. Yeah, and your clinical insight and research insight has been fantastic. So thank you very much.
I think we have time for two more quick questions from the chat, Pascal. One from David P. I very much enjoyed your talk. Is there any AI work on predicting the risk of AV block post-TAP?
Yeah, that's a great question, and that's exactly what we're hoping to look at. So we extracted data set from our STS database and patients who've undergone TAVI, and we've also been able to correlate those with our pacemaker database at the Heart Institute and correlate those. So far in the early analysis that we've done, and that covered roughly 400 patients. Again, it's a small study. We did not find a clear correlation or a predictive value at this time for the amount of calcium and the distribution of calcium in terms of predicting pacemaker implantation. Again, very early data, very small group of patients. And one of the future directions we want to have with this is to create a larger data set that may allow us to better evaluate this in many more patients. I think you'll need a data sets of thousands of patients really to see an effect like this on outcomes. You need to have a lot of pacemaker implantations for us to be able to delineate the effect there.
Okay, and your last question, you're getting grilled this morning. The last question for the morning, did you find any relationship between AI accuracy and demographic features on
Yes.
calcium score prediction?
Yeah, that's a great question. So we did do a baseline analysis. So we did extract baseline characteristics for our patients. We looked at age. We look at sex. We looked at basic comorbidities, diabetes, hypertension, dyslipidemia. We don't have a lot of, unfortunately, we don't have a lot of kind of demographic data on our patients, such as kind of racial descent or ethnic descent, rather. So we did not integrate this into our algorithm, but there was no significant correlation with any of the baseline characteristics of the patients that we find in terms of accuracy of the algorithm.
That's excellent. Thank you so much today, Pascal. That was an outstanding presentation. Really enjoyed it and obviously stimulated a lot of great conversation.
Well, thank you so much. It's been a pleasure.
All right, everyone. Thank you for attending rounds. Please sign up for next week's rounds. The invites will go out shortly. Have a good day.
Thank you.